to this one because here we are, our second session. We are going to be talking about, all right, sorry, we're going to welcome back you to the Whole Person Care webinar series. Of course, I am Dr. Holly Lucille, naturopathic doctor, senior medical advisor here at FullScript, and here for our second session on the series in optimizing hormone balance. All right, so if you missed the first session, we discussed the Dutch cycle map. Don't worry, you can watch the recording at fullscript.com/webinars in a couple of days. And in this particular session, we are going to be discussing the role of saffron, chromium picolinate, and licorice extract in managing mood, sleep, digestion, and food cravings. Okay, so I want to welcome back the doctor who is leading this session, Dr. Melissa Carullo. She is a naturopathic doctor and senior manager of medical information and safety at Metagenics. And again, before we get started, the housekeeping notes, you can submit your questions in the chat and we'll address as many as we can after the presentation. And also the webinar is being recorded and the slides are available right now for download in the files section of this webinar platform. Thank you so much again for joining us. And Dr. Carullo, please take it away.
Thanks, Dr. Holly. Welcome, everyone. It's an honor, as always, to be invited back and collaborate. I'm actually going to jump right in since these sessions are short and very sweet, and we have a lot to cover. So, quick reminder that this presentation is for educational purposes only. It's not meant to replace your clinical judgment as practitioners, although I do have a good influence over you in the next 20 minutes or so. By the end of the presentation, I hope you all will have a better understanding of how saffron, chromium, licorice, B6, how they all work in the body, and then more importantly, how their combined mechanisms just really offer this comprehensive support for downstream effects of normal hormonal fluctuations. Okay, so let's start with the big picture. Women's health is complicated. It's a very dynamic system. There's hormonal fluctuations, metabolic processes, neurochemical signaling, and they all interact. They impact mood, sleep, sleep quality, digestion, and a few other things we're going to chat about today. So this table breaks down how symptoms differ between the menstrual phase and perimenopause. It's really for your reference, but let me just touch on a few things here. So it takes into account how normal monthly hormone fluctuations are going to differ with irregular declining hormones that we would see in perimenopause. So the chart really reminds us that the same symptom, which for example might be like a mood change or a mood fluctuation, may be short-lived and cyclical in a menstruating woman, but then more persistent and unpredictable during perimenopause. Estrogen's effects are mediated through receptors. There's receptor alpha and beta. Estrogen receptor alpha is more proliferative and excitatory in nature. It's linked to cell growth and inflammation, while estrogen receptor beta acts more like a brake. It's anti-inflammatory, it's anxiolytic, it's very protective against overactivation overall. So what's important to note here is that environmental compounds and dietary phytonutrients, they also can influence how these receptors behave. Xenoestrogens bind to both alpha and beta receptors, and they tend to disrupt signaling balance, potentially overstimulating the alpha receptor. This could lead to more downstream, drastic or heightened hormonal symptoms overall. On the other hand, we see phytoestrogens. So this could be compounds such as an isoflavone, and they have a higher binding affinity for estrogen receptor beta. And this may help buffer some of these intense hormonal fluctuations or like balance them out a little bit better. When these external factors are in play, such as chemicals or other stressors around the body or the environment, our normal fluctuations may not feel so normal. So symptoms can become more intense, prolonged. They could be resistant to resolution, and especially in those with additional contributing factors. So if they have a high toxic load or poor detox capacity, we're going to see this show a little bit more with these individuals. Estrogen is also a very powerful metabolic regulator. So estrogen influences key metabolic tissues. This could be liver, adipose tissue, skeletal muscle. In these tissues, estrogen enhances insulin sensitivity and modulates lipid metabolism. And as you might expect, during the follicular phase, when estrogen is a little bit higher, insulin sensitivity tends to improve. But in luteal phase, late luteal phase, as estrogen drops sharply, we're going to see temporary shifts towards insulin resistance, perhaps changes in appetite, or even subtle fluid retention or fatigue. These are all signs of transient metabolic dysregulation. In menopause, where estrogen declines chronically, these effects become more pronounced. So we often see an increase in visceral adipose tissue, mitochondrial dysfunction, and maybe even perhaps a heightened risk for metabolic syndrome in this patient population. Okay, so what about GI function? Often patients that present with GI complaints, the hormonal interaction is overlooked. So if we think about some of the mechanisms, progesterone is going to slow GI motility by relaxing smooth muscle. This would explain the common constipation complaint or a sense of slow digestion just before menstruation. Again, this is a normal physiological response, but it could become clinically relevant when symptoms persist or become disruptive. Cortisol, when this is clinically elevated, we see disruptions in the gut barrier, altered microbial diversity, perhaps a heightened visceral sensitivity, and this could contribute to stress-related GI pain. What about estrogen signaling? So estrogen signaling, this will happen in the GI lining. It's going to help modulate gut permeability, support microbial balance as well. And this will help explain why estrogen fluctuations can influence GI symptoms and why menopausal shifts often correlate with changes in digestion. So here we're looking at the hypothalamic pituitary ovarian axis. So there's a lot going on this slide. I'm just going to hit on some of the key points because I think it could eat up a lot of our time. But this is the hormonal control center that really governs reproductive health and significantly influences mood, energy, and GI function. The axis behaves differently across the lifespan. So it's irregular in puberty, it's cyclical in the reproductive years, and then gradually declines with menopause. So supporting communication along the entire feedback loop with targeted nutrients can really help restore balance even without the use of hormone therapy. Okay, let's look at the neurochemical side of estrogen. This is really very much profoundly influencing mood, cognition, and emotional regulation. So estrogen enhances serotonin synthesis and receptor binding. It will support dopamine signaling and promotes synaptic plasticity. And this is really important because that's the brain's ability to adapt and rewire. This is a huge reason why women with low estrogen often report mood instability, brain fog, or maybe even symptoms associated with depression. Progesterone, this is going to modulate the GABA-A receptor. So that's our brain's primary calming pathway. It's especially relevant in the luteal phase where progesterone should rise and provide this natural calming effect. But in some patients, we see this paradoxical GABA-A response. So instead of feeling calm, they experience this anxiety, irritability, possibly agitation. I think this is a beautiful diagram. I think it explains why supporting hormone health overall is critical in mood disorders. Okay, so again, for a lack of time, I'm not going to detail this slide, but I think it's a great reference as to how it's highlighting that the most sensitive hormonal milestones being postpartum and perimenopause, this is where we're seeing increased risk for mood dysregulation and affective disorders. Both daily and monthly cycles, these are going to shape one's hormone picture overall. So cortisol and melatonin are key players here. Cortisol peaks in the morning, and that's to help, wake us, support energy and focus. But we know that chronic stress can blunt or reverse this rhythm. Downstream, that could lead to fatigue, anxiety, and or weight gain. Melatonin, this is going to rise in the evening as cortisol begins to drop. This will support sleep and reproductive hormone signaling, but we know that with poor sleep, this can disrupt this balance as well and impair menstrual regularity. The menstrual cycle itself can also impact sleep, appetite, and behavior. Typically in the luteal phase is when this would occur. And these rhythms are the basis really for aligning clinically like certain treatment recommendations or lab tests with hormonal timing, because we get a better representation of what might be taking place in the body. Many of the conditions here are modulated, also influenced by these individual genetic or epigenetic factors. So from a nutrigenomic standpoint, variations in genes involved in inflammatory signaling or estrogen metabolism, these may predispose certain women to experience these conditions more intensely and more frequently. And so this means that with the right triggers, such as chronic stress or dietary imbalances, we'll see genetically susceptible women shift maybe from this cyclical symptomology to more chronic hormone-driven pathology over time. So this visual is illustrating just how widespread and disruptive hormone-related conditions are among reproductive age women, and why it's really critical that we go beyond symptom suppression and really address root causes. The conventional treatment landscape, again, we're often going to see some suppression of symptoms. In severe cases, maybe surgery is what's offered. And while all of these treatment options offer more of like a short-term relief for patients, they rarely are going to address those underlying imbalances. And many of these medications are going to come with significant side effects. When we think of integrative strategies, we have, a whole library full of research that's showing botanicals, micronutrients that are offering targeted support with great clinical backing. So in the next few slides, I'm going to review clinical relevance of a few of these, like Saffron, and we'll go through glycyrrhiza, B6, and chromium. So we'll start with Saffron. So this is a powerful botanical. It's gained a lot of traction in the field of mental health and neuroendocrine support. It has a lot of active constituents actually, and not all of them, but most of them have been shown to support modulation of neurotransmitters, in particular serotonin, dopamine, and GABA. So this makes it really valuable to use in clinical practice for mood instability, possibly anxiety, or those diagnosed with some cyclical affective disorder. It also offers a very strong antioxidant, anti-inflammatory effect overall. So this will help reduce oxidative stress, and this is often elevated in these patients, in this patient population. So again, this multi-mechanistic botanical, which clinically could be very useful. So we'll go through a few studies. The first one here we see is looking at perimenopausal women. In this trial, there's 82 women. They're consuming 14 milligrams of saffron twice daily for 2 weeks. At the end of the trial, the saffron group showed 32% reduction in psychological and physical menopause symptoms, and you're seeing that in red on the screen, whereas the placebo group had a 14% reduction shown in blue. Post-hoc analysis was also completed and found saffron significantly reduced anxiety and depression subscores. So again, it makes it a really effective integrative option for mood and stress-related symptoms during hormonal transition for these women. This second study gives us a direct comparison between saffron and SSRI medication in those diagnosed with major depression. It was a 6-week pilot trial in 40 adults. They compared saffron at 30 milligrams per day with fluoxetine at 20 milligrams per day. So depression severity was measured using Hamilton ratings, the Hamilton rating scale for depression. And you can see from the overlapping data points on the screen that saffron was as effective as fluoxetine in reducing depressive symptoms. So again, for any mild to moderate depression, we're seeing that saffron may offer this natural alternative. There's a reduced side effect profile, which is great. And we can also just think about patients who have already experienced SSRI side effects. So maybe they're hesitant to trial another prescription medication. This would be a great option for them. Okay, this table is also for your reference. We just don't have enough time to go through all of the studies, but you can see that it really brings together multiple human clinical trials supporting the use of saffron. So we're seeing saffron clinically validated as this multi-system support tool for mental health, sleep, emotional regulation. There's a few others on the slide here, fatigue, vigor. So you have it for your reference and use it as you may. Okay, so for glycyrrhiza, so this is a long-standing history of therapeutic use, particularly in our industry within integrative medicine. Deglycerized licorice, this form is especially beneficial due to its multifaceted actions. So it's an anti-inflammatory, antimicrobial, and mucosal protective as well. So mechanistically, it's really providing this soothing relief to GI tissues by gently regulating inflammatory pathways, but it has this targeted specificity for mucosal inflammation. So I touched on this on a previous slide, but again, this is quite relevant in menstrual cycle physiology since fluctuations in prostaglandins and inflammatory mediators throughout the cycle are going to often intensify GI symptoms for patients. So modulating these inflammatory pathways with deglycerized licorice can help alleviate cyclic digestive disturbances overall. So this clinical trial evaluated the use of a standardized licorice root extract. It's called GutGuard, and this was in patients with functional dyspepsia. So functional dyspepsia is typically widely recognized as a stress-related digestive disorder, but it frequently co-occurs with estrogen and progesterone imbalances, particularly when prostaglandin activity and visceral sensitivity increase. So sometimes this is a big miss among clinicians. In this study, participants received 75 milligrams of the GutGuard or placebo twice daily. They did that for 30 days. And then following intervention, there was a significant reduction in total GI symptom scores and also in European Dyspepsia Index scores at day 15 and day 30. So improvements were observed across 9 of the 10 symptoms, including bloating, regurgitation, and early satiety. And then also we see that 60% of patients experienced meaningful digestive relief, with some becoming completely symptom-free. So that sounds amazing. The second study was also on GutGuard, but it's actually being completed in those who have confirmed H. pylori infection. So 100 patients, they're enrolled and given either 150 milligrams of GutGuard or placebo, and in this instance for 60 days. So H. pylori gastric load was assessed, and they did this with the urea breath test, but also stool antigen testing. And there were a few notable outcomes. So the first we can see in the table on the screen is a statistically significant reduction in H. pylori gastric load, and that was in those taking GutGuard compared to placebo. At the end of the study, on day 60, 56% of those taking the licorice extract had negative stool antigen testing, versus only 4% in the placebo group, so quite significant. And then similarly, 48% of GutGuard participants had negative urea breath tests compared to 2% of those on placebo. So these outcomes suggest not only a reduction in gastric load, but potential eradication in nearly half of the treatment group without the use of antibiotics. So this positions licorice extract very well as a promising adjunct in a variety of treatment protocols. Okay, chromium. So chromium is very well established. I don't think I have to sit here and convince you of its role in influencing blood sugar regulation. I can go through some of these mechanisms. So if we start on the left-hand screen, we see chromium interaction with AMPK. So it's moving GLUT4 receptors to the cell membrane to allow glucose to enter the cell. And this would be activated when energy levels are low. Moving a little bit to the right, we have chromium enhancing the insulin receptor, so indirectly promoting glucose uptake into cells as well. So chromium is not typically top of mind when we're making suggestions to support hormone fluctuations for a patient. But if we think about the luteal phase of the cycle again, especially the drop in estrogen and the relative rise in progesterone, this fluctuation can lead to altered glucose metabolism and reduced insulin sensitivity. So again, these transient shifts, essentially, we're going to see this demand for quick energy, and this can often present as cravings for sugar or refined carbohydrates, especially in women. For some individuals, we might also see a shift in serotonin and dopamine levels with the cyclic changes and the prostaglandins. So during this time, this could drive emotional eating a lot more intensely for these individuals as well. So by supporting stable blood sugar and insulin function overall, chromium may help reduce these cyclical urges and promote a more balanced energy and mood overall for these women. So this study uses 2 doses of chromium. There's 200 micrograms per day and 1,000 micrograms per day. This is in individuals with type 2 diabetes over a 4-month period. We see the bar graphs on the screen. They are going to represent serum results for hemoglobin A1C, fasting glucose, and fasting insulin. And this is taken at baseline, the 2-month mark, and the 4-month mark. So you can see that the higher dose of chromium shown by the black bars is significantly reduced. All markers are reduced at both 2 and 4 months with the higher dose. The lower dose, though, with the gray bars, we see improved fasting insulin at both 2 and 4 month mark, but looks like it takes a bit longer to see the decrease in hemoglobin A1C. So the reduction is noted at the 4-month mark there, and then not much change at all in fasting glucose. This trial evaluated chromium use in adults with atypical depression. So remember, this subtype is often associated with carbohydrate cravings, fatigue, and weight gain. So participants received either placebo or chromium. They started at 400 micrograms per day, and after 2 weeks, they were increased to 600 micrograms per day. And that was the remaining dose for 6 weeks. So this bar graph's a little confusing, so let me just explain this. So ITT is the abbreviation for intention to treat. So this group includes everyone that participated in the study, regardless of whether they completed the treatment or followed the protocol exactly. Evaluable or per protocol includes only those participants who adhered to the study protocol, so they were compliant and they completed the trial as planned. So those given chromium had a significantly greater response on the Hamilton Depression Rating Scale, and we could see that 65% responded. Those are that's the darker shaded bars versus 33% in the placebo group. Supplementation also led to measurable improvements in appetite regulation and eating behavior. We can see these effects in all participants. So looking towards the last 2 bar graphs on the right, all participants, but even more so in those that were evaluable with high carbohydrate cravings. You could see that chromium showed up to an 80% response rate, which is amazing. So with both of these studies on chromium, we're really demonstrating more robust improvement at these higher doses. So it's really suggesting that perhaps chromium is really working here with a dose-dependent response, and it may be necessary to use such doses to really achieve meaningful clinical outcomes for these patients. Okay, B6. This is an essential coenzyme. It's involved in many biochemical reactions. In the context of hormonal health, it helps modulate hormone receptor sensitivity for estrogen, also for androgens and cortisol. It also supports DNA methylation and will reduce oxidative stress. So this is really critical during high demand phases like perimenopause and postpartum. B6 deficiency has been linked to increased sensitivity to stress and fluctuations in mood. And that's why it's really important to recommend this as a foundation nutrient for those with mood instability. So this study just has just under 500 young adults, so it's pretty large. We're looking at the impact of vitamin B6 on self-reported anxiety and depression before and after supplementation. So participants receiving B6, that's the green bar on the slide, they had a statistically significant reduction in anxiety scores and a trend towards decreased depression. I think what is nice to see here and notable is that there were measurable changes in GABAergic inhibition. Because that's noted, it suggests that this enhanced calming effect took place in the brain with the use of the B6. And this really reinforces what we might see clinically in practice as well, which is this greater calming effect leads to better sensory filtering overall, or better sensory filtering processes. And most of the time, these are going to be disrupted in mood, anxiety disorders, but sometimes also with metabolic conditions. Okay, so just to recap, this is a simplified framework for really just supporting hormone-related concerns using evidence-based nutraceuticals. Can I finish up? Yeah. So the goal at the end of this is really just to help ease the downstream physiological changes that are going to occur during normal hormonal fluctuations. So whether that shows up as digestive discomfort, mood shifts, or cravings for an individual, these changes are going to be subtle for some people, but others, they might be more of an intense response. So this approach is really going to offer this gentle, targeted way to support balance before symptoms escalate or become disruptive. So with that, thanks, Dr. Holly, for letting me finish up.
Of course. All right. We're going to go to questions because, yes, you did such a great job. I know it's a short amount of time, but incredible information. So just one here. DGL you mentioned, and it's interesting, right? So we're thinking about hormone imbalances, and we're thinking about gut, and obviously the body is so incredibly interconnected. Is DGL okay for those with that hypertensive issue versus the licorice that we're used to that is found in a lot of GI supplements?
Yeah, great question. And so, yes, this one has been deglycerized, so there is no worry or concern with any changes in our glucocorticoids. Yeah, we should be good to go.
Yeah, because it's the glycerinic acid that is what we have to sort of worry about. So that DGL increasing mucin does that incredible job. So it's lovely to think about those hormonal things. I do want to ask you one question though.
Sure.
Before we wrap up here and get on to the next session. Do you recommend using hormonal supportive nutraceuticals when patients are kind of experiencing GI complaints? That's their clinical presentation, but they haven't been diagnosed with any hormonal imbalances? Like, what's the nuance there?
Yeah, so I think it could be a yes or no answer, right? So I think just go back to your notes, your history, and if you haven't taken or asked those questions, go back and ask the patient. So I think that if the patient has GI complaints that are cyclical and syncing up to their cycle, then for sure we need to be supporting both. If not, it could be other things, but again, like it's often overlooked, especially in women in the transition phases.
Okay. All right. Thank you so much, Dr. Krulo. Yeah. All right. And thank you all again for attending. Go ahead.
I said, see you next time.
Oh, yes. We're going to see you next time. Okay. If we didn't get your questions answered, I know there's probably a lot out there. You can actually feel free to contact Dr. Krulo directly at Melissa Carullo. Sure. That's M-A-L-I-S-A. Carullo, C-A-R-U-L-L-O at metagenics.com. Again, we're going to take a 5-minute break. Don't forget to exit this session in order to go on to the next. And I'm going to invite you to join me for streaming whole person care. And we're going to talk about clinical tools for supporting hormonal health. And we are going to share practical strategies to help you implement whole person care in your clinical practice. And I can't wait to see you there. All right. Talk to you soon.